Hello, my name is Wesley Lee, and I will be reviewing basic concepts and diagnostic approaches for fetal growth assessment. I do collaborate with the ultrasound industry for development and evaluation of technical innovation, as well as for education as summarized in this slide. After completing this presentation, you should be able to describe the use and potential limitations of population-based weight reference ranges and standards for fetal size assessment, to discuss other approaches for fetal size assessment, including customized growth curves and individualized growth assessment, to list indications for maternal and fetal Doppler ultrasound in detecting and monitoring fetuses with growth abnormalities, and to explain how fetal soft tissue assessment can improve the precision of fetal weight estimation. I will first provide a brief overview of fetal growth to cover basic definitions, describe how fetal ultrasound measurements are made, demonstrate how measurements are used to estimate fetal weight, and explain how these results can be interpreted in different ways based on recent population-based customized and individualized standards. Next, we will review how ultrasound measurements should be used to date pregnancies based on latest guidelines from the American Institute of Ultrasound and Medicine and Society of Maternal-Fetal Medicine. Sections 3 and 4 will explain how this information is helpful for the detection of macrosomic and growth-restricted fetuses, as well as how fetal growth is related to postnatal outcomes and health in adult life. In Section 5, I will describe the role of Doppler ultrasound for the assessment of fetal growth restriction, including parameters such as the umbilical artery SD ratio and cerebral placenta ratio. Finally, I will explain how fractional limb volume, when used with 2D biometry, improves the precision of estimated fetal weight by adding a soft tissue component to the weight estimation procedure. The subject of fetal growth is a clinically relevant topic that impacts everyday obstetrical practice all over the world. In 1954, Clifford was the first to propose an association between fetal malnutrition and intrauterine asphyxia. This concept helped to explain fetal distress and soft tissue wasting in postpartum newborns. Some early work at the Royal Victoria Maternity Hospital in Montreal surveyed a population for fetal malnutrition, as indicated by either soft tissue wasting or low birth weight, on 3,714 live-born infants. In that early work, they stated, fetal growth is a function of both seed and soil. It is dependent upon the growth potential of the fetus and the availability of intrauterine nutrition in its broadest sense to fulfill this potential. The result of these two factors is a wide distribution of birth size at any one gestational age and a wide variation in the state of nutrition at birth. Our ability to detect fetal growth pathology requires a fundamental definition of what is considered normal versus abnormal. This has been an important challenge because of variable definitions used to describe these biological processes. More studies are needed to establish the relationship of fetal size measurements with neonatal growth and clinical outcomes. Much of the way that we currently classify growth outcomes originated from the pioneering work of Lubchenco and colleagues at the University of Colorado over 5 decades ago. Prior to 1967, it was unusual to combine birth weight with gestational age. This work was based on statistical definitions that classified newborns with birth weights above the 90th percentile as being large for gestational age, or LGA, and those with birth weights below the 10th percentile as being small for gestational age, or SGA. This concept was later extrapolated from birth weight to develop estimated fetal weight, or EFW, nomograms for population-based standards. This is illustrated, for example, by the Brenner curve that was derived from a study of 430 aborted fetuses at 8 to 20 weeks gestation and from 30,772 live-born infants between 21 and 44 menstrual weeks in Cleveland. They excluded pregnancies complicated by preeclampsia, breech presentations, Rh disease, diabetes, and congenital anomalies. However, some have questioned the validity of developing nomograms after spontaneous preterm labor because some of these pregnancies may have been abnormal, leading to birth weights that were not truly representative of normal growth. Several mathematical models were developed to calculate EFW using fetal size parameters such as biparietal diameter, BPD, head circumference, HC, abdominal circumference, AC, and femur diaphysis length, FDL. For the BPD, the view is obtained from a magnified axial view of the brain, where the cavum septi pellucidity, midline falx, and thalami are visualized. The cerebral hemispheres should appear symmetrical, and no cerebellum should be seen. The proximal caliper should be placed on the outside edge of bone at the widest diameter of the calvarium. The distal caliper should be positioned on the inside edge of the bony skull. You should be aware that other countries may measure the BPD differently using an outer-to-outer edge method. On the top right, the HC can be obtained at the same anatomic level using an ellipse tool around the outside edge of the bony calvarium. On the bottom left, a magnified transverse plane of the fetal abdomen is displayed. The abdomen should be as circular as possible, with the fetal spine ranging between the 3 and 9 o'clock position. A fetal stomach should be seen on the left side. The intrahepatic portion of umbilical vein should be visualized with no more than one rib visible on each side. The kidney should not be seen in the image. A circumferential ellipse measurement is placed on the outside skin edge, with the surrounding skin being seen in its entirety if possible. Finally, the FDO measures an enlarged image of the entire femur diaphysis length, typically with the ultrasound beam being perpendicular to the long bone axis. The longest visible diaphysis is measured, with calipers being placed at each end of ossified diaphysis, making sure not to include bony spur artifacts at the ends. It is especially important to recognize that birth weight has been used with crown heel length for years by pediatricians for evaluating neonatal nutritional status. By contrast, EFW is a calculated composite parameter that is based on several ultrasound measurements. This calculation process is not the same as placing a baby directly on a weight scale. One Israeli study of approximately 3,700 EFW calculations within 3 days of delivery evaluated 26 different weight prediction models. In most cases, estimates were within 15% of actual birth weight in more than 80% of cases. Despite considerable variation among different models, most results showed good overall accuracy. Models with 3 to 4 fetal biometric indices were found to be better than models with only 1 to 2 parameters for the birth weight range between 1,000 and 4,500 grams. Accuracy decreased at birth weight extremes, with overestimation in low birth weight categories and underestimation for a birth weight greater than 4,000 grams. Model precision was lowest in the low birth weight groups. One group of widely used weight prediction models were reported by Dr. Frank Hadlock and colleagues in only 276 fetuses in Houston. Recognizing the limitations of extrapolating birth weight data to fetal growth curves, they also developed normal predicted values and confidence limits for estimated fetal weight in 392 fetuses. There was a gradual increase in fetal weight from 35 grams at 10 weeks to 3,619 grams at 40 weeks, with uniform variance of plus or minus 12.7%, representing one standard deviation, throughout pregnancy. Traditionally, weight classification cutoffs for SGA, AGA, and LGA are developed from statistical methods and are not linked to neonatal outcomes. Similar to postnatal life, weight below the 10th percentile may occur in the presence of normal fat mass when the child is well proportioned, but only short. Other taller infants, however, could have abnormally low fat mass, but could be regarded as AGA only because they have a larger body. A pediatric study of 159 healthy term and preterm infants used dual energy X-ray absorptiometry, or DEXA, to examine how the birth weight classification system correlates with percent body fat. In term infants, 42.9% of the newborns with less than 10% body fat were classified to be AGA. 9.9% of all AGA newborns had less than 10% body fat. The widely used birth weight centile classification did not closely reflect percent body fat in preterm and term infants. Their results suggest that birth weight centiles alone only gives a rough estimate of neonatal nutritional status. Others have attempted to improve fetal growth assessment by customizing gestational age-specific percentiles based on assumptions about physiological influences on fetal growth. The Diagnostic technique uses stepwise multiple regression to relate factors such as height, pre-pregnancy BMI, ethnicity, parity, and fetal gender to an optimal 280-day birth weight that is predicted for an individual infant given these characteristics. Since not all babies are delivered at 280 days, the target weight is extrapolated to the actual gestational age at birth using a Hadlock proportionality formula. The actual birth weight is compared to the target birth weight. Any newborn with the actual birth weight less than 10th percentile would be classified as SGA by the customized standard. These customized standards are widely perceived to improve the prediction of adverse perinatal outcomes compared with conventional birth weight for gestational age charts. However, their apparent benefits are more likely to have been derived from their incorporation of intrauterine-based or EFW reference values at preterm ages than their adjustment for maternal characteristics. Although maternal characteristics are able to explain population-level differences in birth weight, they are not strong enough predictors for individual-level prediction of birth weight. With maternal characteristics accounting for only a small percent of total factors influencing birth weight, the best estimate of an infant's birth weight remains close to the population average, explaining the ineffectiveness of adjusting for maternal characteristics. In 2014, the Intergrowth 21st project reported the results of a fetal growth longitudinal study to complement international growth standards for infants and children up to 5 years of age. This investigation prospectively scanned 4,321 healthy women from 8 countries. Fetal biometry was obtained every 5 weeks between 14 and 42 weeks gestation. Their primary aim was to develop international growth and size standards that could be used to diagnose fetal growth restriction uniformly and monitor growth from early pregnancy through to the neonatal period. Their analysis suggests no significant differences in fetal growth in measurements taken from 8 geographically diverse countries that justified them to pool the data in the development of their prescriptive standards. In 2015, another prospective longitudinal study of 1,737 healthy pregnancies was conducted by the National Institute of Child Health and Human Development in the United States. Unlike the Intergrowth 21st study that found no differences in the fetal growth trajectories from 8 different countries, the NIH study did find differences among 4 self-reported ethnic and racial groups. In 2017, a third major population-based study from the World Health Organization reported serial scans from 10 different countries for development of fetal growth curves in 1,387 low-risk pregnant women. This analysis was based on quantile regression, and the results were similar to the NICHD study that demonstrated significant variation in either fetal growth or birth weight among different populations studied. In Individualized Growth Assessment, or IGA, Rossovich growth models for anatomical parameters are specified from second trimester growth velocity measurements for a given fetus. This velocity data is obtained when fetal nutritional requirements are low as a proxy for growth potential of a given fetus. The growth models are used to determine expected third trimester growth trajectories and to predict birth characteristics. Changes in a size parameter P during the third trimester are evaluated from comparisons of actual and expected measurements. An important limitation of IGA, however, is the requirement that at least 2 second trimester measurements, as shown by the red dots, are needed to generate expected third trimester growth trajectories. Unlike other population-based approaches that emphasize estimated fetal weight only, IGA accounts for differences in growth potential between individual fetuses for a variety of anatomical parameters. IGA substantially reduces the biological variability that is characteristic of population-based reference ranges because each fetus serves as its own control. In this manner, fetal growth can be assessed by individual or composite anatomical parameters. An essential prerequisite for appropriate evaluation of fetal growth disorders requires accurate assessment of dating pregnancies. The AIUM, ACOG, and SMFM have developed joint guidelines for estimating delivery date, or EDD, based on the last menstrual period and an early dating ultrasound examination that is ideally performed less than or equal to 13 and 6/7 weeks. Women who become pregnant as a result of assisted reproductive technology should be evaluated based on embryo age and date of embryo transfer. This slide summarizes expert consensus for dating pregnancies based on ultrasound measurements of various size parameters. This information should be clearly examined, discussed, and documented in the medical record. Subsequent changes to the EDD should be reserved for rare circumstances, discussed with the patient, and clearly documented in the medical record. Once the dates have been established, one can use ultrasound results to assess fetal size. In this regard, accurate diagnosis of fetal macrosomia is a common clinical problem encountered in everyday practice. Macrosomic infants of women with diabetes are especially more likely to undergo operative delivery or experience shoulder dystocia and birth trauma, including clavicular fracture and brachial plexus injuries. Macrosomia implies a birth weight greater than a specific weight, such as either 4,000 or 4,500 grams. Another way to define macrosomia is based on the 90th or 95th percentiles, based on population-based standards such as this one from the National Center for Vital Statistics. This data consists of 1991 U.S. live births, including 3.8 million fetuses delivered between 37 to 42 completed weeks of gestation. Sherman and colleagues compared the accuracy of routine sonographic EFW to senior residents without any specific training or standardization for clinical assessment of fetal weight. They studied 1,717 laboring women within 1 week of an ultrasound scan. In their hands, 71.5% of the clinically estimated weights were within 10% of birth weight, whereas 68.7% of the ultrasound EFWs were within a similar range. Ultrasound was more accurate for weights less than 2,500 grams. Clinical exams were slightly more accurate from 2,500 to 4,000 grams, and both approaches similarly underestimated fetuses greater than 4,000 grams. One systematic meta-analysis examined 51 accuracy studies for EFW and 12 accuracy studies for fetal AC for over 19,000 women. They found no difference in accuracy between sonographic EFW and AC in the prediction of a macrosomic baby with birth weights greater than 4,000 grams. Given the lack of precision, they could not recommend one method for measuring EFW or AC over another. However, a positive test was more accurate for ruling in macrosomia than a negative test result for ruling it out. An ACOG bulletin on macrosomia concludes that the diagnosis of fetal macrosomia is imprecise. Studies have not clearly supported the sonographic diagnosis of fetal macrosomia because elective induction does not improve pregnancy outcomes. They recommended that labor and vaginal delivery are not contraindicated for women with EFW up to 5,000 grams in the absence of diabetes. However, for EFW greater than 4,500 grams, a prolonged second stage of labor or arrest of descent during the second stage should be considered an indication for delivery. Based on expert consensus, ACOG recommends consideration of cesarean delivery for suspected macrosomia with EFW greater than 5,000 grams in non-diabetic women and greater than 4,500 grams in women with diabetes. Suspected macrosomia is not a contraindication to attempted vaginal birth after a prior cesarean delivery. On the other end of the spectrum, small and malnourished fetuses with growth restriction can also be identified and monitored using ultrasound. DeMarsha-Dimes estimates that 1 out of 12 newborns in the United States are delivered with low birth weight of less than 2,500 grams. These low birth weight newborns will be at increased risk for several complications that include perinatal death, developmental delay, learning disabilities, cerebral palsy, and hearing loss. Unfortunately, we are still challenged with the precise diagnosis of fetal growth restriction, or FGR. ACOG states there is a lack of consensus regarding terminology, etiology, and timing of delivery for the growth restricted fetus. An additional challenge is the difficulty in differentiating between a fetus that is constitutionally small and fulfilling its growth potential and the small fetus that is not fulfilling its growth potential because of an underlying pathologic condition. Referring back to the U.S. vital statistics data, one can see the normal reference ranges for birth weight for nearly 4 million births. The lower white line represents the 10th percentile for weight, the most common threshold below which the diagnosis of fetal growth restriction is often made. However, the challenge lies in how the lower threshold for the diagnosis of FGR is defined. This graph demonstrates the 10th percentile cutoff for 4 population-based standards as compared to the dark line from the 1991 National Standard from U.S. Vital Statistics. The 10th percentile thresholds are similar until about 30 weeks gestation, when there is divergence seen. At 33 to 38 weeks, the 1991 curve indicates greater birth weight than the other curves. As you can appreciate, the prevalence of FGR will vary markedly depending on the growth curve used. Although the 10th percentile is often used as a cutoff, there is some evidence from a review of 12,317 singleton pregnancies at Parkland Hospital that infant mortality and morbidity are increased among term infants whose birth weight is less than or equal to the 3rd percentile for gestational age. Nonetheless, the diagnosis of FGR requires accurate dating criteria and should be suspected with EFW less than the 10th percentile, particularly in the presence of decreased amniotic fluid volume or Doppler abnormalities. We should all remember that there are early and late forms of fetal growth restriction with different presentations that are clinically relevant. Fetal growth restriction that occurs less than 32 weeks gestation demonstrates a greater degree of maternal and fetal vascular abnormalities with a 40 to 70% risk of preeclampsia. Obstetrical management revolves around prematurity and hypertensive disease. However, late-onset fetal growth restriction, greater than 31 to 34 weeks, is more likely to have placental, villus, and perfusion problems that have variable impact on the cerebral and umbilical circulation. The variable relationship between fetal size and Doppler parameters sometimes will confound the distinction between FGR with constitutionally small but otherwise normal fetuses. Management challenges in late FGR centers around failure for a correct diagnosis or timely surveillance that could lead to stillbirth. Careful examination of a severely growth-restricted newborn shows relatively large heads, small or scaphoid-appearing abdomen, decreased skeletal muscle mass with thin arms and legs, and loose skin folds and sunken cheeks due to loss of subcutaneous fat. Among other indices, pediatricians have used ponderal index as one way to identify malnourished newborns. There are many established risk factors for a mother to have an SGA infant. Confirmed maternal risk factors include short stature, low weight, Indian or Asian ethnicity, nulliparity, mother-born SGA, cigarette smoking, and cocaine use. Maternal medical history of chronic hypertension, renal disease, antiphospholipid syndrome, and malaria are associated with increased SGA. Obstetrical risk factors developing in pregnancy include heavy bleeding in early pregnancy, placental abruption, preeclampsia, and gestational hypertension. A short or very long interpregnancy interval, previous SGA infant, or previous stillbirth are also risk factors. Paternal factors, including changed paternity, short stature, and father-born SGA, also contribute. Factors associated with reduced risk of SGA or increased birth weight include high maternal milk consumption and high intakes of green leafy vegetables. SGA infants are at risk for several postnatal problems, including stillbirth. neonatal complications as seen here, neonatal death, cognitive delays in children, and development of adult disease in later life. A prospective study from Finland provides us with follow-up about the academic achievement of 106 SGA infants at age 10. 25% of SGA children were considered school failures compared to 14% of AGA children. Significantly more SGA infants had unfavorable backgrounds and deficient performances associated with poor academic achievement. They concluded that being SGA at birth can have a clinically significant impact on the academic achievement of a 10-year-old child. The maternal, fetal, placental, and genetic factors that can lead to low birth weight also have important implications for SGA children developing diseases in later adult life, including hypertension, diabetes, and vascular disease with regard to the developmental origins of adult disease. As a final note about the detection of SGA fetuses, Sovio and colleagues recently reported a prospective study of 4,512 women with serial-fetal biometry at 20, 28, and 36 weeks gestation. Universal sonography in the third trimester nearly tripled the detection of SGA infants when compared to routinely indicated sonography. They also found value to the serial assessment of abdominal circumference growth velocity for identifying some newborns at increased risk for complications. However, the improved detection of SGA infants could potentially lead to additional false positive diagnoses of growth restriction. Doppler ultrasound can also be used to evaluate fetuses with suspected fetal growth restriction. The Doppler effect was originally described in 1842 by an Austrian physicist Christian Doppler. At that time, he hypothesized that the observed frequency of a light wave depends on the relative speed of the source in relation to the observer, and he proposed to use this concept for explaining the color of double stars. Stars moving away from Earth would lead to a redshift in the light spectrum, whereas stars moving toward the Earth cause a frequency shift towards the blue end of the spectrum. In the 1950s, the same Doppler principle was later applied for detecting the direction and velocity of blood flow in the human body. Blood flow velocity is directly proportional to the product of the Doppler frequency shift and known sound velocity through tissue, about 1540 meters per second, divided by 2 times the transducer probe frequency multiplied by the cosine of the inclination angle. The important thing to know is that when the transducer is perpendicular to vessel flow, for instance, position 3, that the cosine of 90 degrees is 0. That makes the denominator of this equation 0, and under these circumstances, no blood velocity would be detected. However, transducer positions 1 and 5 represent the situation where the blood flow velocity would be the greatest since the cosine of 0 is 1. This explains a very important reason why the detection of blood flow or measurement of blood flow velocity is greatest when the transducer is in line with the direction of blood flow. A review of 5 trials involving over 14,000 women by the Cochrane Review Group does not provide conclusive evidence that the use of routine umbilical artery Doppler ultrasound or combination of umbilical and uterine artery Doppler ultrasound in low-risk or unselected populations benefits either mother or baby. This supports the SMFM's recommendation that until additional randomized trials are completed, Doppler ultrasound should not be used to screen low-risk patients for the development of fetal growth restriction. In 2004, Dr. Bachat summarized progressive changes in fetal cardiovascular and behavioral variables that occur with decline of metabolic status. In most growth-restricted fetuses, these Doppler abnormalities progress from the arterial to the venous side of the circulation. Obvious cardiac function abnormalities are generally not observed until the late stages of disease. The decline in biophysical variables shows a reproducible relationship with acid-base status. If adaptation mechanisms fail, then stillbirth ensues. Doppler flow measurements of the umbilical artery reflects the downstream impedance to blood perfusion of the fetal placental unit. In order to quantify volume flow, one needs to measure the Doppler flow velocity waveform, the area of the blood vessel, and the angle of Doppler inclination. Unfortunately, direct volume flow measurements of small and spiraling umbilical artery vessels are not feasible. So, most obstetricians will use one of three Doppler methods to estimate downstream vascular impedance that will indirectly reflect umbilical flow. The first is the systolic to diastolic velocity ratio, or simply SD ratio, that is commonly used in the United States. Others have used resistance index, S minus D over S, or pulsatility index, S minus D over mean. All three Doppler flow indices are considered angle independent because they are not quantifying flow but rather are based on ratios of systolic to diastolic flow velocity data. Absent or reversed end diastolic umbilical artery flow suggests a compromised fetus. This results from high downstream vascular impedance and also occurs with preferential circulatory redistribution of blood to the fetal brain, heart, and adrenals. Unfortunately, this occurs at the expense of other organs, such as the lungs, intestines, and kidneys. Doppler waveforms from the ductus venosus allow us to evaluate the physiological status of the fetal right ventricle. Ductus venosus waveforms can be obtained from either the transverse plane or sagittal plane of the fetal abdomen at the level of the diaphragm. These waveforms are biphasic, as seen here by a first peak from diastolic filling and a second smaller peak from passive filling in ventricular diastole. The lowest late diastolic velocity represents atrial contraction that is normally found with continuous diastolic flow throughout the cardiac cycle. Potentially compromised fetuses can be suspected when this atrial contraction, or A wave, show decreased, absent, or reversed diastolic flow, especially in growth-restricted fetuses. The umbilical venous Doppler waveform is typically obtained from an axial view of the fetal abdomen. Ideally, the Doppler angle is parallel to venous flow and appears continuous without evidence of significant pulsatility, as one might otherwise detect in severely growth-restricted fetuses. Here are some examples of abnormal fetal Doppler tracings that are associated with increased fetal morbidity and mortality. They range from the reversed end diastolic flow velocities of the umbilical artery, pulsatile umbilical venous flow, and reversed diastolic flow in the ductus venosus. Finally, the middle cerebral artery, or MCA, originates from the internal carotid artery and carries more than 80% of the cerebral circulation. This topic will be further discussed in more detail in our lecture series by Dr. Giancarlo Mari, especially in relation to fetal anemia. In compromised growth-restricted fetuses, the diastolic flow velocity actually increases, unlike the decreased values seen in the umbilical artery. This can be explained by the dilatation of blood vessels to the fetal brain as a compensatory mechanism to hypoxia. If one looks at the complexity of the fetal circulation from Dr. Keith Moore's embryology textbook, one can appreciate the two umbilical arteries that originate from the internal iliac arteries that return blood back to the placenta. If the placental vascular resistance is high, there can be preferential shunting of blood back to other organs such as the kidneys and brain. Some investigators have described a cerebral-placental ratio to describe the relationship of brain to placental blood flow using a ratio of their pulsatility indices, especially associating an abnormal ratio with adverse pregnancy outcomes and postnatal neurological deficit. Dr. Greg DeVore published a summary of the cerebral placental ratio, or CPR, for evaluating well-being in both AGA and SGA fetuses. A CPR value of less than 1 had a sensitivity of 66%, specificity of 85%, and a nearly 12-fold likelihood ratio of adverse perinatal outcome that included intraventricular hemorrhage, periventricular leukomalacia, hypoxic ischemic encephalopathy, necrotizing enterocolitis, bronchopulmonary dysplasia, sepsis, and death. Other investigators have reported poor neonatal acid base status with low CPRs in nearly 3,000 near-term SGA fetuses. Interestingly, the low CPR also appears to predict low neonatal arterial or venous blood pH in AGA fetuses as well. A retrospective cohort study of nearly 10,000 pregnancies examined the umbilical artery pulsatility index, middle cerebral artery pulsatility index, and CPR within 2 weeks of delivery. They found that lower fetal CPR, regardless of the fetal size, was independently associated with a need for operative delivery for presumed fetal compromise and with NICU admission at term. Collectively, more studies are required to more precisely define the extent to which CPR and other fetal Doppler parameters of hemodynamic status can be used to predict pregnancy outcomes and perhaps guide the timing and route of delivery. Finally, I would like to describe the sonographic technique and clinical significance of fetal soft tissue for growth assessment. This MR scan clearly demonstrates the fat and muscle tissue of a developing fetus. For example, the arrow points to a cross-section of the fetal thigh. The lighter area signifies fetal fat, the darker area represents muscle, and the black dot marks a cross-section of the bony femur diaphysis. Unfortunately, it has been challenging for us to accurately and reproducibly quantify fetal soft tissue development using conventional 2D ultrasound. Why is fetal soft tissue important? We know that fetal growth is a complex process, and intuitively, it is easy to understand that we would ideally evaluate this process using a combination of skeletal and soft tissue parameters. I will explain how fetal soft tissue assessment can be used to improve the precision of EFW and now adds another key nutritional component to the weight estimation procedure. As an example, visual inspection of these two-term neonatal thighs indicate a growth-restricted infant on the left and a macrosomic infant on the right side. It is intuitively obvious that these two infants are different, although the degree of malnourishment may only be evident by the soft tissue and not by measuring skeletal structures. That is why conventional EFW calculations typically are based on a composite of head, abdominal, and femur length, although a 2D soft tissue parameter such as mid-thigh circumference is not typically included. If a malnourished patient presented to the emergency room, would it be sufficient to complete this evaluation on the basis of only head circumference, abdominal circumference, and femur length measurements? 3D ultrasound can now be used to measure fractional limb volume, which is a limb soft tissue volume based on 50% of the long bone diaphysis. This fetal size parameter uses software to measure a femur or humerus diaphysis length. The software centers 5 evenly spaced image slices of a limb subvolume that includes fat, muscle, and bone in the mid-fetal arm or thigh. Normal reference ranges for fractional arm volume, AVOL, or fractional thigh volume, TVOL, and reproducibility data have been reported. Fractional limb volume is not only a directly measured soft tissue parameter, but can also be used to improve the process of calculating estimated fetal weight. The ideal birth weight prediction model will produce results that are both precise and accurate. But sometimes the EFW can be precise between several measurements, but not very accurate. Another possibility is that EFW may not be either accurate or precise. Accuracy, or systematic error, can be evaluated by taking the sign difference between predicted and actual birth weight as a fraction of actual birth weight. Systematic errors are a result of potentially correctable factors such as measurement technique, equipment problems, examiner training, or use of prediction model coefficients from a study population that may not be optimized to another group of patients in a local clinical practice. Precision, or random error, was expressed by the standard deviation of these percent differences. Random errors result from the inherent biological variability of the size parameter that cannot be adjusted by correctable factors. However, the size parameter with the smallest random error will provide a level of precision that maximizes the reproducibility of measurements between different examiners. A prospective study of 164 women was performed within 4 days of delivery to validate the accuracy and precision of estimated fetal weight when fractional limb volume was added as part of the weight estimation process, essentially by replacing the femur diaphysis length with AVOL or TVOL. The original Hadlock model, derived from Houston women, systematically overestimated birth weight by 4.9%, although this systematic error was corrected by using a modified Hadlock model with customized coefficients for a local Michigan population. Both Hadlock models gave random errors of approximately 8.4 to 8.8%. By simply replacing the FDL measurement by t-vol, there was a small systematic overestimation of 1.9%, but the random error significantly decreased to 6.6%, exactly the low random error observed in an earlier retrospective cohort that was used to develop these weight prediction models. When the results were stratified by birth weight, less than 2,000 grams, 2,000 to 4,000 grams, and greater than 4,000 grams, one could see improved random error or precision for larger fetuses with increasing soft tissue accumulation. As you can see, the accurate detection and monitoring of fetal growth is a complex topic that requires one to consider how we are applying the concepts we know to clinical practice. A fundamental principle is that we must do our best to establish the gestational age of the pregnancy. Fetal macrosomia can be suspected when the weight percentile exceeds the reference range for a specific population, with the understanding that these calculated EFW predictions are not the same as weighing a newborn on a scale. Fetal growth restriction should be diagnosed with an EFW less than the 10th percentile, especially when the amniotic fluid volume is decreased. The presence of fetal Doppler abnormalities, especially involving the umbilical artery, can be helpful, although there is insufficient evidence from randomized controlled trials to support routine Doppler screening of low-risk fetuses. Finally, fractional limb volume, when used with 2D biometry, improves the precision of EFW and now adds a soft tissue nutritional component to the weight estimation process. This concludes my presentation on fetal growth, and I have listed a few references for those interested in further reading. Thank you for your attention, and please feel free to contact me for any questions.